So now we will begin with the next very important masterclass, and that is on CV risk assessment, how to do it, when to do it, and what are the action-based algorithms that we should be using. And for this, we do have a master with us, Dr. Sanjeev Shah. It's my pleasure to introduce him and welcome him to IDEC 2021. He's an endocrinologist at the Nanavati Super Specialty Hospital. He's been an academician, an avid researcher, an avid teacher, and he's been practicing for a very long time, 38 years to be precise, in Mumbai. And he has had several research papers to his credit. He's done global trials, and I'm very glad to welcome him. He's a very meticulous person, and I'm sure it is going to show through in this particular masterclass. And with him, I welcome his expert speakers, Dr. Pramila Kalra, Dr. Prasoon Deb, and Dr. Tejas Shah. And I request Dr. Sanjeev Shah to introduce his panel.
Our panel consists of very, very young and academic people. Thank you, Neeta, to give me such elite panel. Dr. Pramila Kalra is an endocrinologist, professor of endocrinology at Ramaiah Medical College and Hospital in Bangalore, has an experience of 15 years and 67 scientific publication, and it runs pretty long. So young lady who is going to focus on how do we assess CV risk in diabetic patients. The next slide on Dr. Prasoon Deb is also an endocrinologist at KIMS Hospital in city of Hyderabad. He had been an endocrinologist in Sanjay Gandhi Institute, had been in practice for more than 20 years, and another academic younger person. So he is going to take us in whom, when in a diabetic's life, we should consider screening for cardiovascular risk. And finally, we have a third expert, Dr. Tejas Shah, who is a practitioner in Mumbai. With him, I and Dr. Tejas, we practice in a similar geography in private practice. We have an elite patient population who does as we suggest. We don't have an issue of compliance at all. We have a private clinic with me, Dr. Tejas, and Dr. Prasoon and Pramila. We are going to take you through CV risk assessment. Please note that we are on far more important topic than a kidney, which affects 1/3 of diabetic people. Cardiovascular disease affects almost 3/4 of diabetic patients.
We protest.
The kidney panel would we would request them to continue with us. So we go ahead. Our job is to do CV risk assessment, and the title itself, as if you have read it in the program, has been divided into when, how, in whom. I have taken liberty to combine when and in whom. Probably it gets merged into the similar subject, and finally we end with an action-based algorithm. Our objective is to really carry out a risk assessment. It is quite easy for a kidney group to say that measure microalbuminuria or albuminuria or eGFR, and you have a numerical number. For many patients, 7 out of 10 will have CV risk visible or not visible. And people could be classified into low risk, moderate risk, or high risk. Based on the risk, we have to take a right action in relation to lifestyle modification or in therapy. But most important, we have to select the right patient for a right action. First disclosure, no pharma support for this particular master class or a lecture fees for any of the speaker participants. If I take you through the most important question, are you aware how common is CV disease in diabetics? Presentation and identification is clinically event-based, which we call it a major adverse cardiovascular event. We have learned MACE as an important thing, but epidemiological studies have shown that 1 in 3 patients will have a known cardiovascular disease. If we subclassify people, coronary artery disease 1 in 5, heart failure 1 in 7, and myocardial infarction in 1 in 10, and a stroke in little less number than all this. These are classical MACE event related cardiovascular event. Far more important is the subclinical cardiovascular disease, which we call it hidden cardiovascular disease. If a patient does not get coronary angiogram done or a CT coronary angio, or has not suffered from any CV endpoint, he does not get a diagnostic label. We have to rely on an indirect marker that this individual could have a cardiovascular disease. And some of the studies have shown that 2 out of 3 patients could have asymptomatic cardiovascular disease, which could be significant cardiovascular disease. We have recently learned from Emperor study that there is something called preserved ejection fraction heart failure. So it's not only classical heart failure. So slowly heart failure is getting merged into a cardiovascular disease profile jointly with a MACE endpoint, though many outcome trials were done with only MACE endpoints, and now heart failure is coming as one of an important target. And in a diabetic population, we should not forget a lower limb atrovascular disease, which is a pulseless lower limb, which is 1 in 8 patients. This is all due to what you see here as obese diabetic, which is 2/3 of our population. Insulin resistance is present, and the marker of insulin resistance may be visible to you as high triglyceride upon low HDL ratio. Smoking, physical inactivity, or unhealthy eating may be part of your dietary history. 70% of diabetics will have hypertension, lipid abnormality not reaching an LDL goal or a triglyceride goal could be a very large number. There are non-modifiable factors like age, family history, and non-visible factors like subclinical inflammation or a high visceral obesity may be an important issue. Now I am going to take you through a couple of points on CV risk factors. We have recently learned that we should use a CV risk scoring. A Framingham risk score had been there all along. But before that, this was an interesting paper published by Navid Sattar, who is a great epidemiologist from Glasgow. But he looked at a Swiss diabetes registry, which is one of a very fine registry, and which looked at age at diagnosis of type 2 can tell you about a CV risk. And Dr. Prasoon is going to highlight on whom should we screen. We all know about this is an undergraduate teaching of non-modifiable risk factor. On the right, you have socioeconomic factor. Most important are in the middle two, modifiable risk factor and a lifestyle risk factor. You need a healthcare team to intervene in the direction to modify risk factor. It's very simple, pretty old, 15 years old paper on a Framingham risk. Lot of papers have been written. And if we use all these 6 parameters, on the right extreme, you find diabetes as yes or no, you will be able to predict a risk in large majority of the people. There are many risk factors developed by different groups. For example, I have shown you renal risk factor, which takes into account a high sensitive CRP and a glycemic control. So there can be further sophistication into a risk factor. But we always remain in diabetic population with uncertainty. But whatever you design on a borderline risk, intermediate risk, or a high risk, you have to take an appropriate action on drug therapy, intensity of statin, and a targeted blood pressure control. Finally, I am going to take you through a couple of papers. Framingham heart risk study showed that over 12 years follow-up, simply using clinical parameters could predict a cardiovascular disease. So simple risk scoring is sufficient in long run. A second paper which looked at not only a risk scoring, but also a blood parameters like insulin, IGF-1, CRP, and multiple parameters, and 17 years follow-up showed that CV event rate, whether could be predicted or not. And this risk algorithm concluded that simple clinical parameters in the lab could predict from a primary clinic consultation. And it was as accurate as laboratory based. That means you do not need laboratory to validate the risk, what you predicted based in your clinic on a risk scoring. Finally, a non-traditional risk factor like ankle brachial index for prediction of CV event is not necessary in many people. HSCRP is not necessary, and calcium score is not necessary in every diabetic people. All these tests are to be used judiciously in appropriate patients, and this would get partially highlighted by Dr. Pramila in how to assess risk scoring based on different methodology, clinically and non-clinically. Finally, there are guidelines from ESD 2019 paper published in European Heart Journal in relation to level of evidence, as it's an evidence-based masterclass. We would not be able to highlight here, but I recommend people to read. So your clinical performance in your clinic, in your patients, improves the patient outcome. This requires higher clinical reasoning based on making sense out of a clinical trial data. There is a huge literature published, and we have a solution to clinical problems, which my three expert faculty is going to highlight. With this, here sharing my slides, and I would request my first expert, Dr. Prasun, to take over.
Thank you, Dr. Shah, for setting the context. I don't think JJ's team needs to be worried that we are putting more emphasis on the heart, because most of the patients who ultimately have kidney disease will actually expire through the heart. So everything comes back to the heart. And so we will have our 15 minutes of fame. And let me share my slides. Can you see that? Are my slides visible?
Yeah, they are visible. You just have to make them full screen. That's it.
Right?
Now.
Okay. And there is a little bandwidth issue, so I might actually stop my video sometimes. And since you've already seen my face, you know that there's nothing much that you're missing if my video is not there. So this is our topic, CV risk assessment. Now, by definition, that is when you are sitting in your clinic, a diabetic walks in, he has not yet had a heart disease. Remember that once a patient has had a heart event, then you are talking about secondary prevention. But right now, when you say CV risk assessment, you are talking about primary prevention, which is the patient whom you are going to assess subsequently. And Dr. Shah has already shown you that there are many ways you can risk stratify your patients. Most of these are clinical things. So unfortunately for us, examining the patient properly is still fashionable. You still have to see your patient properly. And most of the risk factors you can assess by clinical features or by simple assessments, which we are doing routinely for all our patients. Why do we need to screen? Who would we screen? And when should we screen? These are the three questions then. Why do we need? Simple answer. It is because it's very common. All the four major areas, CHD, cerebrovascular disease, peripheral artery disease, and aortic atherosclerotic diseases, all four are more common in diabetics, more common probably in Indians. So if your patient is an Indian diabetic, double whammy, you have to be very careful about screening these patients. And the fact that someone has been a diabetic for a very short time does not actually protect him from CVD. Although duration of diabetes is one of the criteria for increasing the risk of that patient. But remember that a 1 year or 2 years diabetic does not protect this patient from CVD, because this slide shows you that hyperglycemia drives microvascular complications, but macrovascular complications actually start much earlier, even before the patient has become hyperglycemic. So the fact that you say that, oh, we have diagnosed this patient 1 year ago, we need not assess, that's probably not correct. So who to screen? Diabetes right up there. But if the diabetic is also hypertensive, smoker, a premature history of CVD disease, CKD, and that is a very big group. If your patient is CKD, then you have to go all out to look at the heart. And obesity. All of these are risk factors to tell you which are the patient that you need to look more hard at. What are the risk prediction tools? Dr. Pramila is going to talk about the specific risk prediction tools. So I'm going to jump over this slide. And what do you do after you have assessed? Now, till now, we have had the ADA recommendation, as you can see. It's a slightly complicated algorithm, but what it basically tells you is look at the risk, and the prescription for that, according to the ADA algorithm, was to decide on how aggressive we will be in the statin therapy. Most of the actionable data on cardiac risk assessment was based on statin therapy. Now, in the last few years, with the advent of the SGLT2 inhibitors, now that you can do something about early CVD and more importantly, early CHF, you now know that the patient need not have a reduced ejection fraction. Even a preserved ejection fraction heart failure can actually be predicted by giving an SGLT2. The Emperor study has shown that. So while we had this ADA algorithm, this was probably not enough because this did not talk about heart failure at all. And the recommendations, as you can see, was based on statins, how much statin, how aggressive statin therapy you would be giving. So we non-cardiac doctors, poor chaps, we did not know what to do about the heart failure, because a patient who is puffing blue, has pedal edema, even the patient will tell you that he has heart failure. You have no credit in that. But what do you do for a patient whose ejection fraction is also not reduced? And that is the group actually where your intervention makes a difference. Till now, we have not had a recommendation which talks about early heart failure. So this was the risk enhancers. If these are there, you will look at the patient more aggressively. Screening for CVD and diabetes, the ADA criteria, which we have just discussed. Finally, the ESC has issued a guideline recently, as of last month, where they are talking about early heart failure and what to do about them. And this is what they say, that signs and symptoms are, of course, a sine qua non. If your patient is having signs and symptoms, the patient has heart failure. But if you are only looking at the 2D ejection fraction number, then less than 40 is a clear-cut heart failure with reduced ejection fraction. 41 to 49 is minimally reduced ejection fraction. And more than 50, which actually looks like a normal echo, this is the preserved ejection fraction. How do you then diagnose these patients? The patient may have symptoms. There would be structural and functional abnormality of the heart, so that diastolic function, which was written in most bottom side of the echo report, is now an important thing to look at. Left ventricular hypertrophy, natriuretic peptides. These are the tests that you then do, which tells you that this is a patient which will probably benefit from SGLT2 intervention. So, do you do this for everyone? The ESC says that if the patient's baseline ECG is absolutely normal, then it is unlikely that this patient has heart failure. So do an ECG like we do in all our clinic patients. If the ECG is absolutely okay, you might not do a 2D echo. However, look for left ventricular hypertrophy, atrial fibrillation, Q waves, and white QRS complex. These are telltale signs that this patient might have congestive heart failure. And those patients then should undergo an echo. And this is the 3 criteria of heart failure that you can diagnose, and then you do something about it. Also, patients who have a history of alcohol abuse, hypertensive, CKD, and a family history of sudden death or cardiomyopathy, these patients also should undergo a baseline 2D echo to find out whether you are missing out anything. So this then basically gives you an overall idea as to how you will go about. Suppose you say that, okay, this patient looks a little dangerous. He has been a diabetic for 20 years. His control has not been great. He is a hypertensive. He has alcohol abuse history. He is a smoker. What do? You do a basic ECG, and based on that ECG, if there are these telltale signs, then you do a 2D echo, or you look at the natriuretic peptides. So these are the ways that you will increase your suspicion and symptomize, go about it. To sum up then, diabetes itself is a CVD risk. The fact that your patient is a diabetic itself increases his cardiac risk. A proper history and an examination will help risk stratification for most people. A baseline ECG is recommended in all diabetics, and this will tell you which patients need a 2D echo. Previous guidelines focused on statin treatment alone. With the rise of SGLT2 inhibitors' importance, heart failure evaluation is becoming increasingly important in the early stages. And these drugs have been shown to be effective in very early disease. And so it's important that you pick up early heart failure. And the recent guidelines has shown the importance of 2D echo.
I've shown 10 minutes over.
Thank you.
Dr. Pramila, take over quickly. Start sharing.
Yeah, sure. I hope my slides are visible. So at the outset, good morning, everyone. And thanks, Dr. Neeta, for inviting me for IDEC, and also Dr. Sanjeev Shah, because he has done an excellent moderation in the past few weeks with us when we have been working on these slides. So my topic of discussion is a little bit concise. Like, I'll be talking about the cardiovascular risk in diabetic patients, how to assess. So I'll be going on with the assessment that how we should do it. Now, many a times when the patient walks into a busy OPD, and we see a patient, we judge in our minds as endocrinologist or diabetologist, yeah, this is a high-risk patient. So how do we do that? So I'll tell you both that ways. One way is through the calculator. The one is how you can judge even in the OPD, yeah, this is a high-risk patient. I need to little bit investigate this patient more. Now, we know that if we talk about the AHA approach, the American Heart Association says that we should do a risk estimation. Then we should calculate the 10-year risk of a first ASCVD event. We can calculate a 30-year or a lifetime risk as well. And this is important because why this calculator is recommended, because this uses diabetes as a risk factor. But we have to understand this does not take into account the duration of diabetes or the presence of diabetic complications. So many a times these risk calculators may not give you a correct estimation. Sometimes you may underestimate. So suppose a patient is a diabetic for 1 year and another patient is diabetic for 10 years. If all the other factors are same, the risk calculation may come the same for both patients, which may not actually be true, because a person who is diabetic for 10 years may have a higher risk. So that is why it is important that we need to have some other factors also as well. So that is one way of doing it. We also have the UK-PDS risk engine. Now, why is UK-PDS risk engine better? Because it takes into consideration the duration. And if you see the UK-PDS ethnic group for which it was validated, it includes Asians as well in a big number. This is the ASCVD risk calculator. You can see you have to put the gender, the age, race, and cholesterol level, HDL level, systolic blood pressure, patient is receiving treatment for blood pressure or not, and only diabetes, not whether the patient has diabetes for 10 years or 11 years, it doesn't take into consideration, and smoker history. So this is a simple calculator which is recommended by the AHA for calculating the ASCVD risk. You can download it from online. This is the download link. You can just download it, keep it as a ready reckoner on your laptop or on your mobile. And when you have little bit of time, just you have to put these things, or you can tell your assistant to put these things. Even the nurse can do that and tell you and write the risk. So that's one easy way to do it. Now, this is a UK PDS risk engine, which we sometimes use for many of our patients in the OPD, because this is a good one in the sense that it takes the duration of diabetes into consideration. So that's why it gives a little bit better estimate. So this is another the engine you can use, and you can again download it and you can use it online. What does ADA says? ADA has a little bit different approach. Now, calculator is okay, but it also says that because it is more of based on statin use, so it will talk more on that lines. So ADA has a clear-cut approach. It says if the LDL is above 100, patient has high blood pressure, smoker, overweight or obese, family history of premature CVD, you can take that patient as a high-risk patient. So this is how ADA also classifies a risk category. Now, all this is okay, but we may say, wow, how can we do this in my OPD? I have 50 patients to see. I can't do this for all my patients. So some things which I said, you can just put it in your brain and you can just revise and see, oh, is my patient fitting into these? So what are the factors to consider? Long duration of diabetes, early onset diabetes, low EGFR, microalbuminuria, presence of metabolic syndrome. This is a little bit controversial because some people say that diabetes and all these itself lead to metabolic syndrome. It's not the other way around, but this is a little bit controversial thing. Severe hyperglycemia, chronic hyperglycemia, NEFL, OSA, erectile dysfunction history. If patient is giving you these history, this should click in your mind that I need to investigate this patient for cardiovascular risk. Another category you can say is higher age, older patient. Gender is a controversial topic a bit, because for younger ones, we know that in younger population, males may be a little bit more predisposed, but as the protection for women go after the age of 45, 50, they may be more predisposed actually to cardiovascular risk. So I would say it is not very clear cut. Family history of coronary artery disease, again, should click that we need to investigate this patient. Blood lipids, very important. We should never miss this because this can give you a good idea. Hypertension. So this is just for a ready reckoner, which you can use it in your OPD and decide, yeah, this is a patient I would like to investigate for the cardiovascular risk. Then there are other tests you do. We normally, if you have a patient who fits into this risk calculator and has a higher risk, you think about doing a baseline ECG and a 2D echo. Treadmill testing has to be done if you are finding everything normal and the patient still has symptoms, you can go for treadmill testing. Then we have non-invasive tests, including the coronary artery calcium scoring, which I'll just talk in the next slide. Invasive tests have to be done only after the cardiologist decides it, because the cardiologists have to do. So this next picture or the invasive test only comes into picture when we have picked up a patient and we know that this patient needs a cardio opinion. So we do a baseline ECG and a 2D echo. If required, do a TMT, and we feel this patient has some changes we need to investigate further, we refer to the cardiologist. Echocardiography is one of the most frequently used tool for risk stratification and to see the patient's cardiac function. Stress echo can be done in those patients where they cannot undergo the stress testing and they have some disability, they have joint issues, and those patients also, or where there is some contraindication for doing the treadmill test. Then if you have a preserved ejection fraction, then you might miss some of the patients here, because ECG, though, as Dr. Prasoon rightly pointed out, that if a patient has heart failure, we'll see some changes in the ECG. We should look for it. We should try to see tachycardia. We should try to see some AF changes. We should try to see the abnormalities in the rhythm. Something we will get there. But suppose we are not getting, and we are still having a high possibility in our mind that this patient is giving some vague fatigue, some weight loss, which is a little bit looking like attributing to the preserved ejection fraction, but I'm not getting that in my reports. There is the point when the role of biomarkers come up. So we can think about NT-proBNP, even HSCRP has been found to be associated with higher risk of cardiovascular disease. Again, we may not be doing it for everyone. So coronary artery calcium score. Now, this is one of the important ways to see the subclinical atherosclerosis. But what we have to understand is that the guidelines in 2018 actually said that it may be considered in adults 40 to 75 years of age who are not having diabetes, who are in the intermediate risk category. They are the ones who can be subjected to this if the decision on the statin therapy is uncertain. If you're talking about diabetes cases and intermediate risk, you can think about. It's not mandatory, it's not needed for most of our patients, but yes, we can discuss with the patient. If you have a high index of suspicion, you can keep this possibility. Carotid intima media thickness and plaque can give you an idea still, because sometimes we always try to see the bruit, we always try to do a clinical examination. We can do a carotid intima media thickness. It can give us an indirect evidence of cardiovascular risk. ABI is a very important tool. I always see to it that when a patient enters my OPD, I at least check the pulses, see for peripheral arterial disease, because these are the indirect markers, which is a ready reckoner. You can just see it in the OPD, then you go ahead with the ABI. It's available always in most of the times in our OPDs. We do it and we see that whether this patient could be a high risk who would need investigation for further cardiovascular risk. So doing an evaluation for peripheral arterial disease is another good way to catch these patients, because this could be indirect marker. As I told, that even erectile dysfunction and all these things can guide you towards the higher risk CV patients. Silent ischemia, we know that asymptomatic patients should not be screened, but don't forget, we should never miss the diagnosis of a cardiovascular disease. Important is not cost effective to screen all. Do a lipid profile, do a blood pressure, check the pulses, do the ABI, get a basic idea, see if the patient is fitting into any of the high risk categories. Can use a risk calculator as well. I showed you the AHA calculator. We also use the UKPDS risk engine because it takes into consideration the duration of diabetes. You can use those risk engines as well, but never miss the diagnosis. If you're in doubt, please do these basic tests. If you still have a doubt, take a cardiology opinion. That is how we should investigate these patients. So with this, I end, and then we can have the questions.
Dr. Tejas, are you ready?
Yeah.
Immediately start sharing your screen.
Yeah. Thank you very much. Thank you, first of all, IDEC team, Neeta, and the entire team. And thank you, Dr. Sanjeev Shah, for coordinating the entire event today. So my role, after my two co-speakers have wonderfully explained regarding the who, when, and how of CV risk assessment, my role is a bit of a mix match thing, where the question was that what do we take into the action-based algorithm, and in discussion with Dr. Sanjeev Shah, it was decided that we will not be going into the treatment aspect at all here. We are primarily talking about a patient who's come into our clinic, who's sitting in front of us, and with the help of our co-speakers, we have already screened them, or we know how and when we screen them for CV risk assessment. And therefore, how do we go forward to decide on the treatment aspect? So let me talk about the case study as an example of a 48-year-old male, known case of diabetes for the last 6 years, who's a smoker, who smokes 5 to 10 cigarettes a day, known case of hypertension since 12 years, doing moderate physical activity, and has on probing further for history, has a typical chest discomfort on jogging for the past few weeks, on 2 drugs of SU and metformin, on antihypertensives, with a A1C moderate of 7.5, with an LDL of 126 and an albumin creatinine already of 50 and an EGFR of 88, and has a CAC score of 180 also. So clearly, if you look at what our speakers have covered till now, it tells us how do we approach a patient who comes to us in the clinic. The first step is to identify the risk factors. First of all, the first step is to assess the cardiovascular disease risk and to determine which are the traditional risk factors which are present. The second step would be to identify the enhancing risk factors beyond the traditional risk factors that are there, that could be present and alter the disease progress further. And then the third step would be to estimate the CV risk using any of the CV risk calculator, which is not recommended for those above 79 years of age, or not required, but recommended for all patients between 40 to 79 years of age. So when you look at this kind of a patient who's sitting in front of us, what we spoke about, it clearly falls into the very high risk category. If you look at the risk stratification for atherosclerotic disease in patients with type 2 diabetes by the latest criteria, any patient with diabetes with an established CVD, or with a target organ damage, or with 3 or more risk factors, or with an early onset type 1 diabetes of more than 20 years duration, would fall into a very high risk category. In our patient, there is already an hypertension present, there is smoking, there is lipids at an LDL of 120 with a microalbumin there. So clearly he's a patient who is in a very high risk category. There are patients with high risk and moderate risk also, depending on the other factors present. With a duration of more than 10 years, you can put him into a high risk, and those with a duration of less than 10 years would fall into a moderate risk category. Identifying the enhancing factors is the next step that we go ahead further, where we look at the various risk factors like premature atherosclerotic disease, hypercholesterolemia, metabolic syndrome, chronic kidney disease, or history of premature menopause, especially in women less than 40 years of age, and high risk ethnicity population present, or as Dr. Pramila said, the importance of ankle brachial index if it is there less than 0.9. The next step would be to estimate the CV risk using a CV risk calculator. Lot of discussions regarding CV risk. I would not be going into the details of that. Any of the CV risk calculators that you can use or you find it practical to use. Framingham was the most commonly used in the past, but we have number of CV risk calculators that have been used. The UK JBS3, then or the which is also modified into a Q risk 3 calculator which we use nowadays, and there are Indian data also with Q3 risk available. So approach would be primarily to assess the risk assessment in this kind of adults. After identifying the risk factors, check the lipid profile. Depending on the LDL, again, if the LDL is more than 190, straight away we go on to the statin. If no, then you need to assess the risk based on age. If the age is less than 40, again, an informal CV risk assessment and assessment for risk enhancing factors. But if the age is between 40 to 80 years of age, we would then be trying to put him into which risk category he falls into. If the patient falls into less than 5% risk category, and then you look at if the patient does not have any further risk enhancing factors, then it does requires lifestyle. If the patient is into a borderline risk between 5 to 8%, you try to estimate the lifetime CVD risk. And if the lifetime CVD risk is more than 40%, then you consider him for a statin therapy. If he falls into an intermediate risk that is between 7.5 to 20%, you straight away again estimate the lifetime risk of more. And if it is again more than 40%, you put him to statin. If no, then you look at other risk factors, whether they are present or no. And if he falls into the high risk more than 20%, you straight away subject him to therapies like a statin and lifestyle changes. In our case, this patient particularly falls into that. Assessing other factors, which I've already spoken about, the three aspects: the calcium score, the carotid intima thickness, and the ABI. Calcium score is something which is a bit controversial here, because we look at the guidelines are clearly telling us to assess calcium score typically in patients which fall into the intermediate or the lower risk category, where it is not very clear, and if it is less than 20%. So which one of the following in this case is true: whether the calcium score is not required for this patient, as it is not a reliable assessment; whether it is in asymptomatic patient, it does not predict the future risk of events. A CAC of 180 clearly suggests a significant extent of coronary atherosclerosis, and that is what we are seeing in this patient. And therefore, he falls into a risk category where he needs an aggressive line of treatment. This is what the recommendations which have been put forward for asymptomatic patients with type 2 diabetes, and routine assessment of microalbuminuria and a resting ECG is what has been indicated now as a class 1 indication, where resting ECG we know detects almost 4 to 6% of patients with silent changes also. And routine assessment of microalbuminuria is indicated to primarily identify renal dysfunction as well as increased risk of future CVD. Role of biomarkers again is a bit controversial. It is not recommended for CV risk assessment, but calcium score is considered and should be considered as one of the primary therapy. A suggested workup clearly would be to assess the patient for smoking, to assess the patient for premature CAD, for looking at his BMI and weight loss, blood pressure reduction, lipid reduction, albumin creatinine reduction. Look at the GFR or the decline in GFR if it is happening, a resting ECG. Looking at other parameters like ASCVD risk calculator and exercise ECG, a coronary arterial calcium score would all be optional, but would depend on the patient's history and patient's present status, whether we require to subject them further. A stress echocardiography may be considered if CVD is suspected and if exercise is not possible. Another case patient who comes to us with a 56-year-old female, known case of diabetes.
Dr. Tejas, 8 minutes over. Your 8 minutes over.
Yeah, last minute. Last minute. Known case of diabetes. In this case, the patient has an additional part of metabolic syndrome with a high triglycerides, and the US is showing a hepatic steatosis and features of NASH and microalbuminuria. We're talking about whether biomarkers in this patient has complained of dyspnea on exertion on coming, and therefore we are trying to evaluate him for heart failure. Heart failure, we know now, has been classified into different stages, and we need to clearly look at what are the clear markers we need to evaluate them. Biomarkers like BNP and pro-BNP have shown importance in patients with heart failure, and clearly we need, along with the signs and symptoms, we need to evaluate them based on the BNP level of more than 125. If it is there, subject them to echocardiography, and then classify them based on their ejection fraction. So to conclude, CV risk stratification in patients should include solely the traditional risk factors with or without risk calculators. Emerging risk factors can be useful, that they may be strongly associated with outcomes. They may be a reasonable potential for classification besides the traditional risk factors. They have good discrimination and calibration and may be cost effective also. Thank you.
Stop sharing the screen. Thank you, all experts. We have 4 minutes left, and if we use an overlap time, we have another 4 minutes. We have very limited time. It would permit me only one question. Everyone has spoken little extra beyond the time. The first question for Dr. Prasoon is, it was very clear from all the talk that patients who have multiple risk factor in a case 1 shown by Dr. Tejas are clear-cut cardiovascular disease looking into your eye. So it's a no-brainer for people and average practitioner that this patient is extremely high risk. You would agree that patients who have symptoms of heart failure are also classical, as shown in the last slide on the right side with reduced ejection fraction. We presume that our listeners will diagnose that also very easily. And lastly, all the patients who have suffered from cardiovascular disease, secondary prevention is again jointly with cardiologists, no-brainer. So we come to a primary prevention, and I put up a question for you that a diabetic at the age of 50, Prasoon, with an BMI of around 27 and has only one associated risk factor, say hypertension in one patient, in another patient only LDL abnormality. Where would you put that patient into? What kind of a moderate risk? You are muted. You are muted.
So this is a moderate risk, you understand, because he's a diabetic. The age is also going against his BMI. His BMI is obese according to Indian standards. So this is a patient where you have already ticked 3 boxes, and you cannot not investigate this patient. In fact, in our practice, however busy it is, there will be very few diabetics who will not require any kind of investigations. Most of those patients will be a diabetic and Indians, and that alone is 2 strikes. So these patients, at least a baseline ECG, a lipid profile, and a proper history, which includes a family history, is mandatory for all these patients. And then you can go further risk stratification, as Dr. Pramila has pointed out.
Pramila, a question for you, that all of us have shown the presence of multiple risk factors is a clear-cut indication for high-intensity treatment, statin, antihypertensive, everything. But the question comes to a kind of a patient who is less compliant on statin or antihypertensive because he believes that doctor is more aggressive and I am not at a lower risk. So how do you stratify such a patient? So how do you give an importance to 10-year risk which looks lower versus a lifetime risk?
It is very important that because there are lots of patients, when we start them on statins, they think the statin is the least important thing and they will always try to default with that. But if I have a diabetic who is more than the age of 40 years, they have to be on a moderate intensity statin. So that is what we know, and their risk is definitely higher. So even if their 10-year risk is showing lower, I'll go with the lifetime risk also for this patient, because this patient has a definitely high lifetime risk because he is a hypertensive, he is having dyslipidemia, he is not taking the treatment correctly. So again, he comes in a high lifetime risk. So this patient would be specifically targeted and will need definite counseling for continuation of the medications, because this is definitely going to be a high risk patient who needs definite statins and with monitoring. So normally we don't do lipid profile before 1 year just to see if the patient is compliant with the medication. But in such cases, maybe we may do it a little bit early to see if the patient is complying. So this patient needs a definite statin therapy, and a calculated risk of lifetime risk would be more important in this patient.
Dr. Tejas, one question for you. The patients with high risk are visible to everybody. Probably patients with extremely low risk is also visible, no hypertension, no renal abnormality, and no lipid abnormality. How out in a busy clinic you would identify a patient with moderate risk?
So primarily we need to screen this patient in terms of their various history. We need to look at their family history, whether there is a presence of prior atherosclerotic disease in the family, history of smoking, history of course, screening them for their lipid parameters, looking at the glycemic control, microalbuminuria, whether it is present or no. All these markers will be telling us whether they are a patient who falls into that moderate risk category or no. One important aspect I think that can help us early to detect these patients is a calcium score, is a coronary CT or a calcium score. If we evaluate them, we know that a score of 0 is more or less safe, but a score between 0 to 99 is what is falls into again that moderate risk category, where you need, these patients may benefit from a statin therapy or going into more aggressive therapy. Anything above 100 we know is again falls into a higher risk category, and we need to subject them to an aggressive therapy. But I think detecting them at a stage where they are between 0 to 100 would be something, because more or less these patients would be asymptomatic and maybe help us to treat them early.
I will stop Tejas here. Pramila, the last question from Dr. JJ Mukherjee. Asymptomatic type 2 diabetic, high risk or very high risk? What investigation to request? How far does one go beyond resting ECG? What is the evidence for that? And an aggressive management of risk factor. You have 50 seconds.
Yeah, definitely. If the patient is high risk or very high risk, then I'm justified in doing an echo and a treadmill test for that patient. If the patient is unable to do treadmill for some reason, then a stress echo. Definitely in this patient, I'm justified in investigating, because there is ample evidence to investigate a high risk patient to go ahead further with the test. But if the patient is a low risk, then the controversy comes, because the studies have not shown that doing a low risk, catching up a low risk patient and investigating them, we are going to change the course much. But a high risk patient, I would say it's justified to go ahead further with the investigations. And also the treatment of the risk will require a high intensity statin, and we'll have to see that if this patient requires antiplatelets as well, if it's a very high risk we're talking about.
Pramila, JJ would like to put a rebuttal, but time shows me 0-0 and time's up. So we will take it for the next session. I admit that we are not complete in this much time.
No, we do have 1 more minute. We do have 1 more minute, because there is a buffer time. So rebuttal,
So JJ, we allow you 30 seconds. We would be happy to listen.
I entirely disagree with the answer. I'm thankful to Tejas that he showed the Diabetes India consensus statement that 10 of us, including Professor Ramachandran, Professor Zerger, and I was there. We put that. Thank you, Tejas, for showing that slide. If you see the ADA 2021 standards of care, if you see what Tejas showed, European Society of Cardiology and American Heart Association 2021 latest guideline, there's absolutely no evidence that even in a very high risk patient, you go beyond asymptomatic. I'm saying asymptomatic. You go beyond an resting ECG, you're making any difference in the outcome. I would request you, this was an evidence-based session. Some evidence should have been given. The Courage trial, the Bari 2D trial. These were people with high risk with established coronary artery disease, more than 50% blockage in 2 arteries. They were randomized into two groups. One group went ahead and did whatever you said, Pramila. Not only that, they had intervention, they had stents put in, they had bypasses done. And the other group only had, I said, aggressive management of risk factors has to be done. You don't have to think about statin. You don't need a CSC score to give statin. Every type of diabetic with moderate to high risk should be on a statin. So if you give aggressive medical therapy versus intervention, be it PCI or CABG, there was no difference.
We incidentally excluded treatment part and intervention 100%.
Yes.
Because we decided to remain only with the risk.
What would you do?
But assessment.
Just a
How
assessment.
you investigate?
Yeah.
If a
How to
patient is high risk,
Only risk assignment and
Well,
not
yes,
intervention.
Prasoon, further investigation doesn't change the outcome. You have to treat the patient aggressively for risk factors. Resting ECG shows abnormality, only then go for treadmill test is of no use, go for some kind of functional assessment. If you do a treadmill, you go ahead and do an angio, you find two vessel disease, you stent the patient, go and see body to the study. There's absolutely no difference in outcome. Ultimately, you are screening for outcome change.
So, Neeta, we
Yes.
need still more evidence-based title.
Yeah.
Probably
Right.
this is the one of a very, very large topic and has
Absolutely,
significant
absolutely.
controversy in the
Very
literature
controversial.
Yes,
also.
yes. Thank you all very much. And
Thank
next
you.
EBM masterclasses will be 1 hour, I promise you, so that there is more time and more interaction. But this has been a fantastic session, lot of food for thought. And I'm sure all the people who are viewing it have immensely benefited from the masters here today. And with this, I close this particular EBM masterclass. Thank you all very